Please welcome Daniel E. Dawes, Meharry Medical College, Dr. Shairi Turner, Crisis Text Line, Hannah Wesolowski, the National Alliance on Mental Illness, and Dr. James Polo, Carillon Behavioral Health.
Good morning, everyone. Good morning. I know we can do better than that. Good morning. It is so great to see your lovely faces. It is wonderful to be here. And I do want to, of course, thank Patrick and Amy Kennedy for always giving equity a space on the agenda. I want to thank all of you for continuing to lead from the front lines, not the sidelines, on this issue. And I think Mr. Armstrong did this a remarkable justice. What a powerful speech, right? Very powerful speech. So, you know, as we were thinking and preparing for this panel, as we thought about 60 years ago, we've all heard about the Community Mental Health Act. We've talked about the mental health reform. I wanted to spend a couple minutes just talking about the confluence of the mental health reform and the civil rights movement. Because over the last several months, as I've spoken with many health equity champions, many behavioral health equity champions, and we have talked about, you know, health equity and operationalizing and achieving and repairing the past, folks will say it's beyond our reach. Any of you had that experience about health equity? Folks saying it's beyond our reach? A few, yes, thank you for being honest. A few have said, you know what, and we even heard folks saying and publishing this in peer-reviewed journal articles. So as I've been thinking about that refrain and thinking about 60 years ago, it's a really interesting time for many of us in this movement. Because 60 years ago, Dr. King, having witnessed not only his arrest in Birmingham, Alabama, in April of that year, then experiencing the Gaston Motel bombings that almost took his life, and then a couple months later, the bombing of the 16th Street Baptist Church where 4 little girls passed away, and the assassination of President Kennedy. About a week before the holidays in December of that year, he reflected and he thought about everything that had transpired. And he came to this conclusion. It's often missed in his speeches. But his conclusion was, we have to go after the root cause of these inequities, these problems in our society. And so, thinking about that, we're hoping that our panel is going to focus further upstream on the fundamental causes of these behavioral health inequities. And we are going to discuss how we can repair the past and how we can operationalize behavioral health equity moving forward. So it is really my distinct honor to have this conversation. But before we begin, we wanted to pose a question to you all in the audience and have you participate with a poll. So I understand there is a QR code that you'll be able to get access to. Okay, good, it's on the screen. And the question for you is, when you think of the factors driving the mental and behavioral health crisis that we're experiencing in the United States, what's the first word that comes to mind? What's the very first word that comes to your mind? If you could take a minute. And then hopefully that will pop up in about 50 seconds from here. And then I'm going to ask the panel to react to that. So let's take 30 more seconds. All right, they're coming up. Wonderful. All right, let's do 20 more seconds. So it's looking like access, stigma, still are the biggest problems, the overarching problems. I'm seeing disparities, isolation, loneliness, racism, that's a good one, inequity, structural discrimination, structural bias, criminalization. All right, thank you all so much. So let me ask our panelists, to react to that? You're seeing a host of factors that have just been raised. What factors do you perceive to be driving the rise in mental illness and substance use disorders, specifically exacerbating mental health inequities among different population groups in the United States, especially minoritized groups? And what are some of the potential reasons for those existing inequities, and how can we address the alarming trend? I know it's 3 questions in one, right? I hate to do that to you all. But what say you? And let's start with
So the word cloud is not a surprise, right? Why we're here, just all of those factors contributing, driving into access. So for those who aren't familiar with word clouds, the largest, most bolded word is the one that most people chose, right? So access is something that came to mind for everyone. As a little bit of context, so Crisis Text Line provides free 24/7 mental health support and crisis intervention in English and in Spanish, and we're one of the largest backup lifeline providers for 988. So given that context, we look at our data around minoritized populations. We know that 70% of our texters are under the age of 24. And of the 1.3 million conversations that were had by Crisis Text Line volunteers last year, 37,000 of those conversations were Black texters, 45,000 conversations were Latinx texters, and 20,000 were Asian texters. And I think what's the reason, right? Why is that happening? And I think fundamentally we have to start with recognizing and acknowledging the structural racism and structural issues as a foundation. Then we're layering upon that gun violence, mass shooting, political unrest, the whiplash of summer 2020 George Floyd to where we are now, right? But then when we think about, the civil rights era, right? What could we say about the mental health of Black people during that time? Suicide rates during that time. We know that they've increased, but we really couldn't capture the data. We didn't use the words. We didn't have the language to be able to explore those concepts anyway, right? So to be able to say in the civil rights era, were Black people and people of color feeling oppressed, depressed, anxious? Of course, right? But we didn't collect that data in the way that we do now. So gathering the data gives us power, right? And gives us understanding. So hopefully we're then able to take action. But what's different now than then is, without judgment, but just acknowledging media and social media, right? Because where mass shootings, gun violence, the pandemic, all of those things are now constant, right? Letters from a Birmingham jail, not texts from a Birmingham jail, right? There's an immediacy to every experience, and people of color live in a collective, right? So this morning, listening to the shootings at Morgan State, the HBCU in Baltimore, I immediately thought about my son, who's a junior at Howard in DC, right? And it's like that collective experience, because if that could happen to those students, it could happen to my child. And I think people of color just experience the world in a collective way that makes all of this layering that's happening just so cumulative and so pervasive.
Great points. Hannah?
Yeah, I love your point about layering, because it is about the different layers. No one's identity is one thing. There's so much intersectionality, and I don't believe that we've ever really understood or acknowledged that appropriately before. The structural stigma that we see and discrimination that we see is a huge factor here. We also know there's an enormous lack of access, as we see in this word cloud. We have data that shows we have many more therapists in white affluent communities than we do in Black and brown communities, or communities with lower income. And those things all have an impact. Vic Armstrong talked beautifully about the fact that if you don't have providers that look like you or have a shared experience with you, the impact of what they can do for you is different than what the rest of us experience. And I think our political environment tells so many people that what they're going through, what they're experiencing, what they believe is wrong. And we can't ignore that either. Certainly our LGBTQ plus community is experiencing a lot of concerning trends over and above the trends we're seeing in Black youth suicide. We know that 2 in 5 LGBTQ plus youth contemplated suicide in the last year. 2 in 5. I mean, that's just horrific to think about. And we have unprecedented number of laws across the state being proposed that tell these kids that there's something wrong with them, that how they identify, who they are, can't be accepted, and that they shouldn't talk about it, they shouldn't get care, that it's not okay to be identified based on their true identity and their genuine self. So, I think all of these things layer in a really tough environment. The racial injustice that we see and what we've experienced since George Floyd in 2020, compounded with just 160 million Americans living in a mental health provider shortage area. There's just not enough workforce, and there's not the right workforce to be there.
That's right. Thank you, Hannah. Jim?
Well, first of all, I'm not surprised by the word cloud either. I look through the lens of being a child psychiatrist for the last 35 years. So, I've lived the world of stigma and access for decades now. And when I think about it, in healthcare, ultimately, at the end of the day, it's a supply and demand problem when it comes to mental health. We have a demand for services for our communities, and we don't have all the right resources to meet that demand. Now, as a physician, I've always felt that patients with mental health problems, mental health challenges, emotional instability, they are already marginalized by the fact that they're seeking mental health. And in fact, for years, they haven't wanted to talk about it. They don't want to park in that parking lot for anybody to know that that's what they're doing. They're already marginalized by themselves, and they're already marginalized by the society around them. So now when you think about equity and how much we're learning about disadvantaged communities, these individuals that are vulnerable for a racial reason, a social reason, a financial reason, a gender reason, and now you layer in mental health, they're marginalized twice now. So this whole idea of equity is, how do we make sure that communities thrive, which is really about making sure everyone in the community thrives. So we really have to think about that to make sure that we can really take care of everybody. And I think in these last 2 years, what we've learned in the pandemic is, look, if we're going to face challenges that affect everybody, then we're going to have to come together if we want something to happen. Now, we did that with COVID. We talked about that yesterday, how quickly we came together to be able to think about how we're going to address the COVID crisis. This mental health crisis has been around for a long time. It is not new. And the fact that we have equity issues in our community, which are woven right into our structures, is also not new. So we have to come together in a different way. We have to come together in a way that really thinks differently about what it is that we're trying to achieve. And what Patrick told us yesterday is, we're not going to get a second chance to get it right. We've got to get it right now.
That's right. And if we don't get it right, I know Hannah and I, we released a report in D.C. looking at the economic burden of mental health inequities, and we found that over a 4-year period, that 117,000 lives were lost. And that's with limited data. Imagine how much more that number is. And it was costing us $278 billion for our failure to address mental health inequities in America. So I want to pivot and go to my mentor and dear friend David Satcher. Dr. Satcher, as we all know, have said that there is no health without mental health, and he's argued there is no mental health equity without, or there is no health equity without mental health equity. And so I wanted to ask you all, what does mental health equity or behavioral health equity mean to you, and how do we know when we have achieved this?
Right, great question. So I think mental health equity means that regardless of your race, your gender, your ethnicity, your socioeconomic status, your immigration status, you have access to, and I like to think of it as a physician in the ways we think of, there's like 5 R's of medication management, but thinking sort of the 4 R's. So the right service. So what's the right mental health service for you at the right time? So prevention, if I'm in a crisis, is too late, right? What's the right provider? So speaking to cultural competence, speaking to workforce development so that people have a provider who looks like them, who can understand. And I guess I'm going to pause there for a second, because why is that important? Why is the difference between a culturally competent provider, which is important in and of itself, and a provider who looks like you, who's had your experience? Because you can sit there and have a conversation that doesn't require you to explain what it means to be Black in America, Native in America, Asian in America, right? Like that conversation doesn't have to be had. You can jump to what are your mental health issues. So having the right provider, and then the right modality, right? So if you prefer by text, if you want to see someone in person, if you want to do something, telemedicine is best. Mental health equity means that all of those R's are available to everyone, regardless of who they are and what their life situation is.
Good point. Hannah?
Well, I should have said this before. For those of you who don't know NAMI, and hopefully most of you do, we're the nation's largest grassroots mental health organization. So we're comprised of lived experience, individuals and families who are affected by mental illness. And what we are always looking at, all of the things that you said, but, every person deserves the opportunity to lead a healthy and fulfilling life. And making sure that everyone gets that opportunity, because that's not happening right now. Something we didn't talk about in the first question was policing and mental illness. And we know that people with mental illness are much more likely to come in contact with law enforcement and the criminal justice system. We know that our Black and brown communities are much more likely to come in contact with the criminal justice system. NAMI did some polling, and we found that about half of white adults said that if they had to call 911 for themselves or a loved one who was in a mental health crisis, they'd be afraid of the response. It was 80% for minoritized communities that are afraid of what will happen if they make that call. No one should be afraid to ask for help, and until we have a system that treats mental health like health, we are not going to be able to give people the response that they need.
Great. Thank you, Jim.
I look at this through a lens of being on the payer side. So, in my current role, I have oversight for about 90 million Americans, ensuring that they have access to good, high-quality mental health care. So, first concept is the idea that you can separate emotional well-being from physical well-being has never made sense to me. They are intimately tied together. And so internal to the health system, we've sideloaded these two arenas as if somehow they're separate. And that has nothing to do with communities that are marginalized. We've done that for everybody, okay? When it comes to thinking about the idea of what is mental health equity really all about, in my mind, it's about ensuring that everybody in the community has an opportunity to achieve emotional well-being. But emotional well-being for one individual in one community might have a different meaning than for a different individual in a different community. And what it means is we have to begin to understand all the different elements of that community, whatever community you want to talk about, and take those factors into account so that every individual truly does have equal opportunity. Now, one of the challenges with this is that there are so many things in our society that pull us apart at the same time that we have this inner human drive to just belong. We want to be part of the community at the same time that we want to celebrate our differences. So it's a huge challenge. From my perspective, I simply say to myself exactly what Shairi is saying. How do you make sure that every individual, regardless of their background, gets the right treatment at the right time by the right person for the right reason? That's the way our health system is supposed to be driven. That's the way most of us operate when we're actually in the room with a patient.
So Jim, let's go with that question, right? How do we actually achieve this? How do we operationalize behavioral health equity? It's a common question folks ask. It seems like this, I think you described it as this mythical creature, right? in many respects. So how do you actually operationalize this? And let's begin with you, and then I'll come down this way.
You know, I get this question asked a lot. I had a previous job where I was hired to be the behavioral health expert, and I felt like they were checking the box. Hey, behavioral health is important. We're going to hire a smart guy that knows something about behavioral health. We've done it. And what I've learned is that approach doesn't work. When something is critically important, you have to weave it into the entire culture, the entire fabric of the organization. So as a physician, I say to myself, I want to achieve equity for patients. I want to achieve equity for our communities. I have to start internal to my own organization. My organization is 100,000 employees, 100,000 associates. Do we have equity in terms of how we work with each other so that that will then flow from how we think into what we do serving other people on the outside? I'm a firm believer you can't achieve anything that you're not willing to do yourself. If you're an organization that wants to really achieve equity for whomever you serve, you have to live it, breathe it internally in yourself and in your organization first.
Great. Hannah?
Yeah, I mean, I think there are a lot of ways we tackle this. There's no single solution to look at it, and I think that's a perfect example of what needs to happen. There was a lot of conversation yesterday that we don't often look at outcomes. We don't really look at the quality of care and what outcomes we're achieving. And I think we can look at that at a variety of levels, but if we're not really measuring how people's lives are impacted, how they are doing 1 year, 5 years, 10 years. I've worked a lot on the crisis response side of things, as I know you have too. And, are we measuring if, people are getting a mobile crisis response? Are they going to jail or are they going to the emergency room? How does that change based on their race? Are we looking at that? Are we making sure that the people who are impacted are at the table helping to propose the solutions? I think inclusion is the most important aspect here. Nothing about us without us, and making sure that we have those voices at the table, and making sure that table is representative of what we're trying to do.
Great comment. Yes.
I would have to agree, well, with both, but Jim in particular with leading by example. So at Crisis Text Line, one of our values that's on our website is center equity, right? How do we operationalize that? We have and continue to have, since we first established our JEDI office. So justice, equity, diversity, and inclusion, where many organizations now have dialed back those positions. We have continued, we have a vice president and we have a project manager, and their job is to ensure, working with all the teams, because it's not just on them, that we are embedding equity in everything that we do. And what does that mean? That means the 60,000 volunteers that we've trained to help texters have a cultural competency module so that they know exactly how to work with texters of any gender, any race, how to be inclusive. Our staff have gone through that very same training. And we just continue to elevate it. When we look at our partnerships, right, we assess where our potential partners are on the spectrum of equity, right? So anybody who's diametrically opposed, that's not going to be a good cohesive partnership. But in other spaces, like we look to, well, can we lead this partner by example? Can we show them what we're doing with our staff, what we're doing with our volunteers, and what we're doing for our texters?
Thank you for that. As I was listening to you all, you highlighted some obstacles that you've encountered, or in general we've encountered in advancing health equity, behavioral health equity in particular. So you talked about rolling back some of the DEI initiatives. We talked about workforce as well as data being foundational to a lot of this work. So Jim, I wanted to quickly ask you, what obstacles has your organization faced in promoting mental or behavioral health equity, and how can those be addressed? Very quickly.
Yeah, very quickly. I think one of the challenges is that people are defining these concepts sometimes in different ways. You have to settle on what it is that you're really talking about when it comes to equity in a community. What are we trying to achieve? You have to make sure that you level set, that everybody knows what we're talking about, and then you have to have a directed strategy to get there. You have to decide, what is it that we're trying to achieve? What are the actions we need to put into place to get there? What are the things that we're measuring to check and hold ourselves accountable to actual progress?
So you talked about strategies, and Shairi, I want to ask you, about your current strategies or policies to promote mental health among your employees, among customers, business partners, and how might they, enhance, of course, and promote behavioral health equity?
So really elaborating on
Yes.
what I had
Yeah.
started to say before, but we focus. I think it's about continuing to have the conversations, continuing to do the training for staff. It's about having dialogue between staff. It's about the partnerships, again, always looking for partners who can allow us to get into communities of color, right? So we can't be everything, but we want to, it's intentionality, right? So it's the intentionality of finding partners who are out in communities where there's less access and where having a text, the ability to text for mental health support, it could be the difference between no support and getting any type of support. So again, it's really what I said. It's looking at every layer. It's about what are you putting out, in your marketing, in your value statement, in your mission statement, and then what do you embed at every level, no matter what the organization is, whether it's staff or volunteers, and then just reflecting on it and gathering data. The other piece is the data that we're able to gather from our anonymous post-conversation surveys. We're always looking at by demographic, by gender, and even elevating when we don't have data. So for if there's not data around Native American individuals, we highlight that so it doesn't become an absence of an individual, but saying there wasn't data or the data wasn't available.
I love that you all take a comprehensive and reticulated approach to this, right, in terms of development of strategy and programs. Hannah, let me go to you quickly then and talk about, you talked about NAMI. NAMI is, quite an influential organization, and I'm curious as to what ways your organization or an organization can leverage its power and influence to promote equitable mental health, behavioral health practices among, your partners and vendors.
Yeah, we've been looking at this in a number of ways. I mean, first, we've really encouraged community conversations. We have initiatives, Sharing Hope and Compartiendo Esperanza, which are about having conversations in communities by community members. Again, this is about making sure that lived experience is centered in the conversation. And, while people have the best of intentions, kind of coming up with this concept, but not having the people who are actually impacted at the table is not going to be effective. We have seen too many times in this country that we have great ideas that have a lot of potential and we abandon ship, particularly in the behavioral health space. We had the Community Mental Health Act. We never fully funded it. We never fully funded a community mental health system. We've now seen in the Bipartisan Safer Communities Act a path forward to make sure CCBHCs can be everywhere, and that's amazing. Coordinated specialty care, another opportunity to make sure everyone gets the care they need. And we had really sharp increase in availability, and then it leveled out. And we maybe can reach about 10% of the people who have an early episode of psychosis every year. Again, all of the evidence is there and we abandoned it. 988, well, it's waiting for a point of crisis and that's not what we want. This is an opportunity for us to actually fully implement a solution that can be the jumping off point to getting further upstream. And so what we've been doing is trying to bring together partners. We heard yesterday, it's not about us in the mental health space, it's about everyone. And so we've brought together major county sheriffs, League of United Latin American Citizens, American College of Emergency Physicians, a national PTA, a group of more than 50 organizations that are not necessarily your traditional mental health organizations to be part of the solution. And if we stay confined to just our community, the mental health and addiction community, we're not going to be able to embed this across the spectrum of our nation and make sure it is embedded in everything that we do. We need to get that buy-in from everyone who is impacted, and that's what we've been trying to do.
I love that. You know, all good things must come to an end, as they say. And so I wanted to see if I could squeeze in one more word, because you all talked about measuring behavioral health equity and inequities. You know, what metrics, very quickly, in a few seconds, what metrics can be used to track progress toward behavioral health equity? Shairi, do you want to go first, or should I not put you on the spot?
What metrics can be?
Yeah. Or why don't we go, Jim, why don't we go with you first then?
Yeah, I live my world in metrics, tracking metrics to make sure that everybody's getting what they need. You know, these metrics might not be metrics that we know of right now. I know one thing. We're not going to get there by only using financial metrics. We have to get away from thinking about the business side of what we do in healthcare and think about what we're trying to actually do with our communities at large. You know, Mahatma Gandhi said that the measure of any society, the value of a society is measured by how they take care of their most vulnerable individuals. So for me, this is about who do we want to be? Where do we want to go? What legacy do we want to leave behind? And what are we personally willing to do as an action to make that happen?
Thank you. Hannah, how about you? What metrics?
Yeah, I love that point. You know, I think we all, you know, to your point that we may or may not know what it is in the healthcare space, but I don't think we can be limited to just the healthcare space. Mental illness impacts the full spectrum of a person's experience. We need to look at the social determinants of health. We need to look at our what's happening with criminal justice and diversion and policing of people with mental health conditions. We really need to look at that full spectrum to make sure, again, are we achieving what an individual wants to achieve in their life? Are we really focused on where they want to go and what their goals are?
Yeah, absolutely.
Yeah, I would just echo the same. We're going to need to continue to look at and gather the data, right, and get granular with it and be very specific and intentional about what we're looking at and what we're measuring, and be willing to get real with what we find, right, and take action on what we find.
And I, you know, just want to bookend that with a comment. You talked about social determinants of health. I think the path to behavioral health equity is paved with the determinants of health, and I just want to add the political determinants of health, being able to measure that and incorporating that into our work as well. So we are out of time. Unfortunately, I know we could speak for another 30 minutes, but why don't you join me in thanking our distinguished panelists, please, for their brilliance. Thank you for the privilege of your time.
Thank you, everyone.